acute appendicitis. And these images are all from CMC Union. My patient was a 3-year-old African American female, and she was referred from Union Urgent Care to CMC Union. She presented with symptoms of lethargia, moaning, and chills. She had a fever, nausea and vomiting, and severe abdominal pain that her mother said she had been experiencing for the past 18 hours. Her mother let us know that she had been constipated for about 4 days, and she had given her Miralax 2 days prior to her presenting to CMC Union, but other than that, the child had been perfectly normal. She had just gotten really sick within the last 18 hours or so. A right lower quadrant ultrasound was ordered to evaluate for appendicitis. And before we get into the images, these are just some images I pulled from Google. This shows the sagittal view here in the transverse. And this is a little stone called appendicolith that is often seen with acute appendicitis. And I just wanted to go over the, how the process of this exam would look, since we don't often see them. We use a high-frequency transducer, of course, and we know from studying that when the appendix is inflamed, it's non-compressible. We use graded compressions. This gradual pressure that we use helps displace the bowel gas so that the appendix can be imaged. Typically, the appendix is located anterior to the iliac vessels. It doesn't always live in that area, but that's a good place to start looking for it. And then the wall thickness should not measure greater than 2 millimeters, and the diameter outer to outer wall shouldn't measure larger than 6 millimeters. Transverse, as you can see in the far image over there, is a target sign or bullseye sign in transverse, and then the appendicolith is the echogenic area with the shadowing, which is the stone, and is often present. So here are our images from this case, and this is the sagittal view with and without color. Here you can see it's a little hypervascular on the right image. And then this is transverse. And this echogenic tissue surrounding the appendix is called periappendiceal fat, which is due to the inflammation. And here in our top image on the left, you can see that it was non-compressible. And then on the right, there's an appendicolith stone there with a shadowing down posteriorly. And these are just 2 more images as we scan through in the sagittal view. And then after we image the appendix, we just check for abscess and fluid collections in each quadrant. So this is just documenting that we evaluated, and there didn't appear to be any fluid collection or abscess from this acute appendicitis at this time. And here's the midline pelvis area, and she also had this in the lower quadrant and right lower quadrant. And this is just the dilated loops of bowel that were present that we were having to use the graded compressions to kind of work through and see the appendix actually within the bowel. This is our worksheet. And then the official report from the doctor was the appendix is enlarged up to 9 millimeters, hyperemic, non-compressible, and has a mildly thickened wall. A trace amount of free fluid is present in the right lower quadrant, and a focal fluid collection is not clearly seen. However, multiple inflamed appearing small bowel loops are present within the right lower quadrant. So the impression was acute appendicitis. And I chose this exam for several reasons. I felt that appendix can be intimidating to us as students as well as new graduates because we haven't seen that many. And I had seen a couple but never positive until this case. And when our patient presented to CMC Union, she was obviously very sick. Like immediately upon evaluating her, and her mother was like very concerned. She wasn't responsive. She was very lethargic. She moaned continually throughout the exam. So we had to work quickly to accommodate both her and her mother since she was so sick, and her mother was very concerned. So as we were imaging the appendix, I noticed that even though there was a lot of bowel present, it didn't take that long to actually see the inflamed appendix. It seemed like it was pretty easy to recognize, which I've heard sonographers tell us multiple times that when it is actually inflamed, it's not as difficult to image. So that was encouraging to me. Not for the patient, of course, but that it was pretty easy to recognize, even with all the bowel that was present. So, also So 50% of patients present with periumbilical pain, nausea, right lower quadrant pain, vomiting, and fever. And with this case, we saw all of these signs. Another thing that's often seen with acute appendicitis is rebound tenderness, which is known as the McBurney sign. And we didn't know that this patient actually had one because she didn't seem to just seem in any worse pain at any time during the exam. But I just wondered if she was too sick to even realize that she was so lethargic, and she really wasn't responding to us at all. She just kind of acted the same throughout the entire exam, and until we got her sent off for surgery. So she was actually transported to CMC Northeast for surgery. Her mother worked there, which was a surgical tech, and so the doctor she worked with was actually going to do the surgery. So we kept her there at Union for a little while to just keep her comfortable until they could get everything situated. But she was really sick. And here I just wanted to kind of go over what exactly the appendix is. It's a long, thin diverticulum that arises off the inferior tip of the cecum. The average length is 3 inches.